All right. Okay, I see people in the waiting room, but I can't get to them. Give a few more. There are some folks joining us right now, so we'll give them a few more minutes to come in. All right, I think we've got a nice group here, and there may be a few other people trickling in, but I think we've caught most of the folks that will be joining us today. And I would like to welcome you to the second session of the webinar series on genetic services in Appalachia. We ask that you mute your microphone for the talk and place any comments that you have in the chat. We ask that you not record our session. We will be recording the session and providing a transcript on our webinar website. So we are happy for you to go back and listen, and anything that you might have missed, or you can review the transcript. We're happy that you're participating and interested, and we will do our best to get the information to you. So at the end of the session today, we will ask for your assessment and feedback. If you have had a chance to review the previous session and haven't had a chance to do the evaluation from last month, we appreciate you going in to do that. It's just helpful for us to have that data to provide as kind of a summary to our session, and also to give us feedback. And so we did review the feedback from the last one, and we've tried to make those incorporate those changes going forward. I do need to make a correction. I had pronounced Anusha Sheikh's name incorrectly in the previous session, and I did want to alert you to that. I'm also pleased to note that we have Brenda Harding joining us, and she was very instrumental in talking to some of my ideas about thinking more about genetic services in Appalachia. We had discussed some different options, and this was one that she thought maybe a nice way to set the stage for doing more work in this area. So we are appreciative of the help and assistance and funding from AHRQ. So now, as you know, our aims are to develop a research agenda for genetic services in rural Appalachia. And each month we'll be having speakers who are working in genetic service provision to medically underserved populations with a focus on setting a research agenda in rural Appalachia. And so I would now like to introduce our speakers, Ms. Margaret Owl and Ms. Justine Pekarsky. Margaret Owl is the genetic counselor supervisor for pediatric genetics and metabolism at University of Kentucky Healthcare. Thus far in her career, she's cultivated genetic counseling expertise in a variety of settings, including research, public health, and pediatrics. As part of the pediatric general genetic counseling team at University of Kentucky, she's privileged to serve as a guide on the diagnostic odyssey and engage in shared decision-making with patients and families being evaluated for a wide range of indications. She completed her master's degree in genetic counseling at the University of Cincinnati and Cincinnati Children's Hospital and has a master's of bioethics from the University of Pennsylvania. So a lot of intersectionality, a lot of our Appalachian population also in Ohio and in Pennsylvania. And we'll be hearing more about Pennsylvania next month. So now Justine Pekarsky is a licensed genetic counselor at the University of Kentucky Markey's Cancer Center and is responsible for providing programmatic leadership for genetic counseling services at Markey Cancer Center. And she was one of the first people that I spoke to about putting together a webinar. And so we've been very pleased that University of Kentucky is working with us. She's provided genetic counseling services to patients in Kentucky for over 10 years and has helped establish outreach clinics and telehealth services for cancer patients and their families. So with that, I'll turn it over to you, Margaret, and if you're able to share screen, and I will mute myself and I will watch for any comments that are coming in to the chat. Thank you.
Excellent. Thank you so much for that introduction. I believe I am sharing my screen. Hopefully everyone's able to see it. So I'll be talking a bit about the general genetics side of genetic and genomic healthcare at UK Healthcare. I am trying to advance my slides. There we are. I have nothing to disclose. And I think you can't talk about Kentucky without talking about counties. Kentucky is a state that's really defined by counties, and I practice in Fayette County, which is right there, kind of in the middle. It's not technically a county within Appalachia, but borders Appalachian counties, and we serve patients really from the center part of the state to the easternmost parts of the state. The only other pediatric and general genetic clinic in the state of Kentucky is located in Louisville, in the Jefferson County area. And our clinics generally divide the state in half, with the Louisville clinic providing services to the western part of the state and our clinic providing services to the central and eastern part of the state. Justine and I also wanted everyone to be aware that the state of Kentucky has established licensure for genetic counselors starting in 2018. And these are the tasks that we are allowed to perform under our license. getting family histories, medical histories, talking about genetic diagnoses, identifying and ordering genetic testing, which is kind of a yes and no situation because we are not yet recognized by Medicare and Medicaid. CMS ordering is sometimes tricky. And integrating those diagnostic studies with the personal and family medical histories, talking about the implications of genetic diagnoses and results of tests, and providing client-centered counseling and anticipatory guidance, identifying and utilizing community resources for support and advocacy, and documenting our patient interactions. So now on to the genetic and genomic services at Kentucky Children's Hospital, which is where I practice within the University of Kentucky Healthcare. It is the largest children's hospital in the state that I'm aware of, and we have the largest NICU in the state, most definitely. We offer pediatric specialty services not available in other parts of central or eastern Kentucky, and care for some of the sickest and most medically complex children in Appalachian Kentucky. So you can see here the volumes of admissions and our capacity. I noticed Dr. Zhang is on, and I did want everyone to know that we have a genomic laboratory, a clinical genomics laboratory available to us at UK Healthcare. And they are set up to offer a number of genomic tests, including chromosome microarray, Fragile X testing, a number of cardiology gene panels like aortopathy panels, cardiomyopathy, arrhythmia gene panels, things like that, as well as clinical exome sequencing. And our team in pediatrics has partnered with our pathology department to provide some limited genetic counseling support for test utilization management and coordination. And there is an open laboratory genetic counselor position available. If anyone is interested, I'd be happy to talk with you. Our team in the clinical genetic side of things is encompassed by a number of key personnel. We have a physician geneticist, Dr. Stephen Kaler. He is our interim chief of genetics and metabolism and works part-time remotely from Arkansas about 3 out of 4 weeks per month. We do have some open physician genetics, geneticist positions. We also have 3 advanced practice nurse practitioners, Paige Matheny, Angela Kretcher, and a new hire, Cassie Starks. I think I can let everyone know who she is, as well as 3 genetic counselors, myself, Miriam Bunch, and Hillary Rieger. And then we have a nursing team, a nurse team leader, a registered nurse, a nurse navigator who primarily works with coordinating the newborn screen results, not just inborn errors of metabolism, but all newborn screens that flag for central and eastern Kentucky. And we are in the process of requesting an additional registered nurse position. We also have 2 metabolic dietitians and additional support staff, including a patient navigator and 2 other administrative support staff members, one of whom is designated as a genetic counselor assistant. The patient population we serve is quite broad. Even though we are located within a pediatric clinic in the Department of Pediatrics, we see patients of all ages. Most of them reside in central and eastern Kentucky, but occasionally we'll have patients from western Kentucky. Sometimes I'll see patients from West Virginia, and I believe my colleagues do as well. And over half of our patients have some type of Medicaid insurance plan. We provide services both in an ambulatory setting and through inpatient consultations. For ambulatory appointments, we offer telehealth and appointments in person in our clinic. Since the pandemic hit, we switched to majority telehealth appointments and have continued that to this day. At this point, about 80% of our ambulatory appointments are performed by telehealth. For inpatient consultations, most of those they're going to go directly to the physician or the nurse practitioner on call. The genetic counselor may be involved with those to some degree, and we have started to pilot a genetic counselor only inpatient consultation for children who are coming into the hospital through the child neurology service for epilepsy. We also provide evaluation and counseling, like I was saying, for a broad range of indications, basically everything except hereditary cancer indications and prenatal or preconception indications. We also at UK Healthcare, in addition to Justine's team, which she'll tell you about soon, we have a prenatal genetic counselor in our OBGYN department. My team is also involved with providing newborn screen follow-up for infants who flag as positive for inborn errors of metabolism. And as I was saying, we provide some limited genetic counselor support for our pathology department for lab test utilization management. Since we are located within an academic medical center, we have a medical school and a number of other graduate and undergraduate programs. We do host a number of students in our group, medical students, residents, genetic counseling students, undergraduates and graduate students. The genetic counseling students are from outside institutions, UK, and really any other institution in Kentucky does not have a genetic counseling training program. There's no such program yet in the state. So some information about our volume. I think we have been quite successful in spite of a number of challenges with pandemic and staffing, and have been able to increase our patient and appointment volumes dramatically in the last 3 years. It says appointment volume and not patient volume because our physician or nurse practitioner may have an appointment with a patient, but we have started creating a separate appointment for genetic counseling visits if the patient is also seen by a genetic counselor on the same day. And that was really initiated in 2020. We also, that same year, initiated genetic counseling only appointments, and these are mostly for disclosure of results or providing pre-test genetic counseling, usually for second tier testing like exomes or gene panels. In 2020, we also hired our third genetic counselor, so that allowed us to increase volumes, and as a group initiated telehealth. In 2021, there were some staffing changes. Our physician geneticist at the time relocated to another state, and one of our nurse practitioners retired, and we're now working on replacing them. But even with those challenges, we've managed to increase our appointment volumes. In terms of getting compensated for our services, the majority of this will come from reimbursement for visits with the physician or the nurse practitioner. We also do get some funding from the state of Kentucky through a grant for newborn screening for providing follow-up services for individuals or babies in the central and easternmost parts of the state. We have tried billing for genetic counseling. The genetic counselors have tried billing for those services, but we found that there was such a low rate of reimbursement for genetic counselors that at some point we questioned if it was worth continuing to attempt billing. Since such a high percentage of our patients have some Medicaid plan, most of those we're not getting, all of those actually we're not getting reimbursed because we're not recognized as providers, genetic counselors as providers by the Centers for Medicaid and Medicare. So we were also concerned that these patients might be getting some balance bill, and we are at this time not billing for genetic counseling services. We've had some ongoing discussions about other options for billing, but haven't yet found a solution. For our community outreach activities, these are mostly encompassed by the educational piece that's baked into being part of an academic medical center. But a number of my colleagues have given talks to community groups that we often see patients within, such as the autism community, the Autism Society of the Bluegrass, and the Down Syndrome Association of Central Kentucky, or DSAC. And we have been very busy with genetic counseling students from other programs, providing some supervision for those students. Some opportunities that I see for expanding genomic services within our institution and in the state of Kentucky would be to potentially resume outreach clinics. That's not something that we are currently doing. There has been a long, very, I think, successful history of geneticists like Dr. Brian Hall traveling out to Eastern Kentucky and actually meeting patients where they're at. So I think there's lots of wonderful opportunities there, but we do need the staffing to support those outreach clinics. We also, I think, could provide more services through multidisciplinary clinics. And there are some areas, including a new clinic that's just gotten off the ground that we've started to be involved with for disorders of sexual development or differentiation. There's also talk about perhaps starting a Down syndrome clinic that we could be involved in, and there are undoubtedly many other opportunities for multidisciplinary clinics. I think the creation of low literacy genomics educational tools within our institution and beyond would benefit our patients a great deal. Perhaps having videos that they can watch that we can bring in on an iPad or a computer, or providing some very general basic written materials would be really helpful. A lot of our patients, when they come to us initially, have a limited understanding of what the role genetics plays in their healthcare. So even having something that explained that to them before they are seen, before the visit, I think would be helpful, and perhaps improve show rates, things like that. I've also been thinking about how genetic counselors might be integrated into other areas beyond genetics and metabolism in other specialty clinics. With our inpatient consultation for child neurology and children with epilepsy. I've also had some discussions with pediatric primary care about the possibility of integrating a genetic counselor within that sort of practice to perhaps initiate some of the genomic workup for kids with developmental delay or multiple congenital anomalies. Right now, our wait for an appointment in genetics is into the summer of 2022. So perhaps having a genetic counselor available to some of those clinics where there might be first-tier testing that they can, assist with and make recommendations about, I think could be beneficial. And that is all I have. So I am going to stop the share and hand it off to Justine.
Right. So let me get my sharing going. You guys can see that okay. All right, so good afternoon. I'm happy to be here today, and also just wanted to thank the organizers of this series for inviting me and Margaret to share what's going on at the University of Kentucky. And Margaret's done a great job going over some information about UK and Kentucky, and specifically about the general genetics and pediatric world. I'll be sharing our experience at Markey Cancer Center. And while we have genetics across different specialties at UK, One thing to point out, and that Margaret alluded to, is that we are all housed within our own respective departments. And so that I'm at Markey Cancer Center, Margaret's with the Children's Hospital, and then our prenatal genetic counselor is housed within the MFM clinics there. So we are not one combined group necessarily. So these are my disclosures. I am a consultant for my gene counsel, however, that shouldn't impact any of our discussion for today. And you saw this map earlier today with our many counties across Kentucky. Those that I have circled in blue are the counties where there are genetics providers who are available in person, cancer genetics providers. So Fayette County there in the middle, again, that's where we practice in Lexington. There are 7 genetic counselors across the hospitals here in Lexington who will see patients in person. Kenton County up at the top of the state is near Cincinnati, and they have several genetic counselors that are in northern Kentucky. Jefferson County is where Louisville is located. So again, they have several cancer GCs practicing there. The 2 counties that are circled that are the farthest west and the farthest east, so Davies and Pike County, each have 1 provider. So Davies County in the west is where Owensboro, Kentucky is. So that's not technically part of Appalachia. They have 1 genetic counselor there, and she started about a year ago, and she's the first genetic counselor that they've had there. In Pike County in the far east, so there is a nurse practitioner who goes to that clinic, so not a genetic counselor, but a nurse practitioner who has special training in cancer genetics. And she comes, I think, last I heard it was twice a month that she goes to that clinic, and she actually comes from the University of Tennessee in Knoxville. So she's been doing that for, I think, over 10 years. So she's provided services to that Appalachian area for quite a while. And then here circled in yellow that you can kind of see, those are areas that we at Markey provide telegenetics services. So those are sites where the patient goes to the hospital in that county. And UK has an agreement with that institution, and we see the patient via telehealth. And I'll talk a little bit more about that in a bit. So a little bit here about Markey Cancer Center. So Markey has been around since 1983, and we are Kentucky's only NCI designated cancer center. We first received that designation in 2013, so it's been a number of years. Since 2017, we've been ranked in the top 50 cancer centers by the US News and World Report. So as you can imagine, we're a top cancer center in the US, let alone the state. So we do have many patients who travel to see us from across the state or even across state lines. So kind of a wide population that we see. Markey does see over 100,000 outpatient visits each year. And in 2020, there were over 34,000 unique patients who were seen. And we have a number of different support services at Markey aside from genetics. So you can see those listed there: PT, social workers, financial counseling, and a number of others that I probably didn't include there, but lots of services for patients. Markey has a network of affiliate hospitals, which is the Markey Cancer Center Affiliate Network, or MCCAN for short. And this is an affiliation that started in 2006 and is now a group of 20 hospitals located throughout Kentucky, and they are shown here on this map. And as you can see, they are spread throughout the state, but quite a few of them are in the Appalachian eastern part of the state. So Markey provides cancer-specific education and training for these community doctors and nurses and staff to ensure that they're getting the most up-to-date cancer information and that that's available to providers. Markey also helps to assist these cancer programs in achieving and maintaining Commission on Cancer accreditation. And they also provide services such as genetic counseling that many of these hospitals do not have, because these are typically smaller community hospitals. So we provide telehealth to these hospitals and patients. However, not all of these sites choose to use our telehealth services at UK. And the goal of the MCCAN network is really so that patients are able to get quality cancer care close to home without having to constantly travel several hours to get their cancer care. So this just shows like where we get our referrals from, specifically for cancer genetics. And this is data from 2020. You can see here that in the dark blue, almost half of our patients are referred from within Markey, so our own oncologists referring patients. About 11% are from these MCCAN sites, so that's in that light blue section, and then 19% of our referrals in 2020 were, which is in that green section, so those are patients who are referred from UK providers, but not specific to Markey. So think primary care doctors, OBGYNs, gastroenterologists. And then that little 4% in yellow, those are, that's a smaller community hospital here in Lexington that UK has a partnership with. And then so overall, only about 11% or so of our referrals in 2020 were from outside institutions that have no real affiliation with UK or with Markey. And then that 9% in the gray, those are self-referrals, many of whom are family members of patients that we had previously seen and may have recommended testing for those family members. So a little background about our team here. So I came to Markey in August of 2016, and at that time I was the only genetic counselor and we didn't have any dedicated support staff. And then prior to 2016, Markey had had genetic counselors, but had only ever had like one at a time. And the plan when I came in was to build more of a program and be able to provide more cancer genetic services to patients. So when I came on, they had been without a genetic counselor for almost a year. So there was a lot of backlog and things to be done there. So I came on in 2016, and this is again just a timeline kind of showing what's happened since then. Within a year, we did hire a second genetic counselor, Tara Lucas. That position was already approved at the time that I was hired, but it took a little while to get someone to fill the position with staffing issues and just a shortage of providers, genetics providers. And then we hired a coordinator and assistant in January of 2018. And then we hired a third genetic counselor in August of 2019. During the pandemic, there were some staffing changes. So then some of our assistants' duties had changed and we had a scheduler assigned to us in July of 2020. Then you can see we lost a genetic counselor in August of, she left in April of 2021 to pursue a fully remote telehealth position. And then in May of this year, we had one of our nurse practitioners at Markey completed the cancer intensive course through City of Hope. So she's primarily using that training to help run a high-risk clinic at Markey. And then in July, we hired a replacement for the GC that we had previously lost earlier this year. So Michael Goski is our third genetic counselor now. So our team is still fairly small. So there's just 3 genetic counselors. Our scheduler and our coordinator are both shared positions. So most of their work is with genetics. I would say over half of what they end up doing is time spent with genetics, but they are shared roles. So they're kind of equivalent to 1 FTE total. And then this is a list of our services that we provide. So of course we do ambulatory, in-person, and telehealth consultations. We rarely will see patients inpatient. The vast majority of ours are in-person and telehealth consults. And currently over half of our consultations are through telehealth. Prior to the pandemic, only our MCCAN patients were seen via telehealth with those agreements, but that has COVID changed things. And so we are still seeing the majority of our patients through telehealth. The genetic counselors attend several oncology tumor boards. So there's a number of those throughout the week. There's about 9 that us genetic counselors attend. So we split those up amongst us. And then we do review somatic test results for molecular tumor board. So typically there's about 15 or 20 cases that we review a week. And many of those are not from Markey. We get a lot that are across the state that outside providers are sending to our molecular tumor board for review. We, of course, have those MCCAN telehealth consultations. We do have a couple of high-risk screening clinics at Markey. The GI clinic is one that we just started in July of 2020. So that one's pretty new, and that's the one that that nurse practitioner has started that clinic, and then we've had a high-risk breast clinic for a number of years. January of 2020, we started a pediatric cancer predisposition clinic, and this is a clinic that Margaret's team provides some input on as well, depending on the patient's presentation, but that's a clinic that we've primarily taken on since it's cancer predisposition. We're on a number of committees, so cancer committee, survivorship committee, our GCs are on several different committees. And then we often get pulled into different research projects and ideas to help provide input or oversee some of those, and lots of education to providers, patients, and students. So our patient volumes are here, and this shows our patient volume since 2017. These are calendar years, so 2021 is not yet complete, and these are data through September. And these are just for our genetic counselors. So I think also different than a lot of the pediatric and general genetics clinics is that all of our visits are GC only visits. So as you can see here, our volumes have increased over time as we've been able to add more genetic counselors and have some more support staff. In 2020, we did start seeing all of our patients via telehealth for a period of time, thanks to the pandemic. And as I said, now over half of our patients are still seen through telehealth. And we're giving patients the option of doing either in-person or telehealth, and many of them are still choosing to do telehealth, so they don't have to travel or take off work. And many patients who are undergoing cancer treatment may have lots of other visits, and so it's just one less thing they have to come to the hospital for. In 2020, there were an additional 131 patients you can see in that light blue. So those are patients who underwent physician-initiated testing through our pancreatic protocol, and those are in 2020 and 2021 there. And in the next few minutes, I'll talk a little bit more about that specific protocol that we have. So this physician-initiated testing for our pancreatic cancer patients is an alternative service delivery model that we started in January of 2020. For those of you who are not familiar with a lot of cancer genetics, they do recommend that all patients who have pancreatic adenocarcinoma should be offered germline genetic testing for hereditary cancers. And this was a guideline change to MCCAN criteria that happened in 2018, so kind of in the middle of 2018. And the testing is recommended to be done fairly early in the time of diagnosis and treatment, because the cancer type has high mortality, and the genetic testing can often help determine whether there are specific treatments for the patient. And of course, it can have implications for family members and inform them about cancer risks. So while many of our providers were referring these patients, there were a number of patients who were unable to be seen because they weren't able to travel back and forth, or they were too sick, or unfortunately, some of them would pass away between the time the patient was referred and then the time of their appointment. So there was 1 week late in 2019 that I had like 5 of these pancreatic cancer patients on my schedule, and I didn't end up seeing any of them because they were all too sick to come in for their visit, or had gone home with hospice, or had already passed away. And so that week kind of prompted us to really look at our model and come up with a way to ensure that patients were able to have testing done, because often they were being referred, but they weren't able to be seen or have their testing done. So the genetic counselors, along with our medical oncologists and our surgical oncologists, we all work together to come up with a workflow to help improve the access to germline testing for these patients. So this is the outline that we have for that workflow. So basically, when a patient comes to the clinic, if they have pancreatic cancer, the clinic staff gives the patient a family history questionnaire to complete. It's not as detailed as what our genetic counselors would get, but it does help provide some additional information to ensure that we're ordering the most appropriate tests for the patient. And then the patient meets with their provider, and the physician or the nurse will discuss the option of genetic testing with the patient. We created a fact sheet with frequently asked questions, and we asked that the providers use that fact sheet as a guide to help lead the discussion and address questions. Then the patient is given that fact sheet, which has our contact information on it. And the patient can decide then if they want to do testing or if they want a more typical pre-test genetic counseling session. So the genetic counselors are very involved with this process, and we review the family history questionnaire, help coordinate testing and document things in the health record. And we do contact every patient with the results once they're available. So even if their results are negative, that just allows us to have a touch point with the patient, ensure that all of their questions are answered. And if there's any follow-up that needs to be had with family members, we can talk to them about that. If the patient does have a positive test, of course, we typically will try and schedule them for a more detailed consultation to review the results and implications for family. And those can be done via telehealth, or if they're coming back into the clinic, we will try and see them the same day that they're being seen at Markey. So what has the impact of this been? So in 2019, we tested a total of 13 pancreatic cancer patients. Again, many more than 13 were referred, but they were often not able to be seen for a number of reasons. So 13 in total. In 2020, which is when we started this, we blew past that low bar of 13 patients within the first month, and we tested 131 patients in 2020. So this process really did improve the number of patients and family members that we were able to impact. Of that 131, about 40 of those were diagnosed with their cancer prior to 2020. So we were picking up not just the newly diagnosed patients, but some of those who had lived with their disease for several months or years. And then in 2021 so far, we have, and this is again from a couple months ago now, but we've tested 75 patients this year. We do expect this year that we'll have a lower number since we aren't really playing catch up like we were last year with some of those patients who had previously been missed. So now you can kind of say that our genetics team also includes our surgical oncologists and medical oncologists to some extent, since they are involved in the genetic testing process more than they historically have been. We've seen that a lot of the providers have gotten really engaged with genetics and cascade testing and those sorts of things. And you can see here they got a little competitive sometimes about who was testing the most patients. So this picture is one of our surgical oncologists, Dr. Michael Kavnar, and he sent this picture through email to us and said #winning this day that he had seen a number of pancreatic cancer patients in clinic. So it was exciting to see those providers getting interested and having a little bit more engagement with genetics. So talking about the money, so we do bill using the 96040 code for the patients that we see at Markey. I think that was all put in place before I came, and we've still always done it, but there is still a low reimbursement rate for services, as Margaret discussed earlier. Our MCCAN visits are a little bit different. So these are currently done with institutional billing, and this is something that may change as contracts change, and since our telehealth services have changed over the last couple of years since the pandemic. So the current process is that the referring institution is billed a flat fee per patient. So it tends to be better on our end financially, since it's a guaranteed amount of money and is often more than what the insurance companies would reimburse us. And then another way you could kind of look at reimbursement, and not something that we have specifically looked at UK, but there was a study just recently published in ASCO from the cancer genetics team at UT Southwestern. And with their study, they found that one full-time cancer genetic counselor would generate $1.49 to $1.86 million in revenue each year, just looking at screenings and preventative surgeries and things that would be done as follow-up. And this study only looked at patients who had a BRCA1 or 2 mutation or Lynch syndrome. So if you think about all of the other hereditary cancer syndromes that also need extra screenings, or even patients who are high risk just based on family history alone, I think that number would probably go up. So return on investment is quite good, because $1.49 to $1.86 million is much more than a genetic counselor's salary. So again, not something we've looked at specifically at UK, But I think it would be interesting to see what our reimbursement might be there. And we do some community outreach activities, although being in an academic institution, a lot of our community outreach is within our own UK community. So we do provide quite a bit of education within UK and within Markey through grand rounds, lunch and learns, and those types of things. We also give talks for different groups, so residents and fellows. The action program here at UK, which I wanted to point out specifically because it's an interesting group of high school and undergraduate students here at UK, pertinent to this talk because it stands for the Appalachian Career Training in Oncology. So this program gives these students from Appalachia an opportunity to gain some experience in cancer research and clinical and outreach education experiences. So the goal with that program is to help these students from Appalachia be interested in oncology care and hoping that they will pursue a cancer-focused career. We do quite a few presentations for outside hospitals, and Markey does conferences every year. They host a few of those. And then with our MCCAN hospitals, we provide several outreach or presentations and educational events for them. We do supervise genetic counseling students from other institutions, as Margaret said, and then prospective students, so undergraduates or high school students who may be interested in pursuing a career in genetic counseling. And then we do have presentations for community groups that we've been asked to do. So I've listed a few of those here. Those have been, of course, a little more minimal over the past couple of years with the pandemic. Okay, and then in our last few minutes, I've got a couple of slides here that Margaret and I had put together kind of about combined observations for our patients at UK. So I'll ask Margaret to comment on anything that I may miss on her end or things that that are specific to her clinic. So some of the barriers and limitations are here. And I know Margaret had mentioned earlier that previously there was a lot of many outreach clinics, which are not currently possible due to staffing limitations. Many of our families, both in cancer and general and pediatrics, travel several hours each way for their appointments. So it can take 2 to 3 hours, definitely a barrier for patients. And telehealth has improved this for many of the patients, although not everyone has access to telemedicine. They may not have broadband internet or reliable cell phone service. So we do tend to have many patients who have low or no health literacy, or no literacy, period. And especially when it comes to health literacy, that can be a challenge in working with some of these patients. And then, as Margaret also mentioned earlier, they're currently scheduling into summer of 2022, so that can be a challenge for patients to have to wait that long before they're able to be seen. And again, the low rate of reimbursement for genetic counseling can make it difficult to hire additional staff and to make it a top priority for some of the administrative side. Anything to add on those, Margaret?
Absolutely. I think the staffing and the reimbursement are connected, unfortunately, but we do have staffing needs beyond just the genetic counseling teams with physicians and for pathology genetic counselor who wouldn't be billing.
Yeah. And then some anecdotal observations. Margaret, do you want to do this one?
Sure. Yeah. I had mentioned that a number of our patients and families are unsure of the role the genetics teams and genetic counselors have in their care or their child care. So perhaps creating some materials for preparing families and patients for visits could be helpful. I've practiced in other areas of the country, both coasts, and am originally from the middle. So what I've noticed about patients here in Kentucky is that they are less likely to ask questions of their healthcare providers, maybe more differential to the provider's expertise in the decision-making process. We in pediatric genetics and metabolism have a high rate of complex patients with multiple medical issues. in Justine's area, later stage cancer diagnoses, social health issues. Kentucky has some of the highest rates of kinship care in the country. So in pediatrics, that means we are seeing children who are not in the care of their biological parents, sometimes in the care of a great grandparent or an aunt, uncle, cousin, or grandparent. And what I've also noticed is interesting, and Justine probably has as well, is that many patients, family members are still in the state. Lots of folks live in Kentucky. Their families have been in Kentucky for many generations, which can be helpful in the case of cascade testing. And patients in general prefer and report they are satisfied with their telehealth appointments. Our genetics and metabolism telehealth service has consistently received patient experience awards. So I think this is an opportunity to expand access to genomics and genetic care in Appalachia, just a matter of making sure that people have access to the technology so they can have a telehealth appointment.
I think that's all we have. So I think that does leave some time for questions
Thanks, ladies.
or discussion.
I'm going to go ahead and place the evaluation form, and please let me know if you don't see it. And so we appreciate you completing that evaluation form just to give us some feedback and to know what you as a participant, what your goals are, and how we might modify the presentation for the future. And I will start us off and just ask one question. And if you had to pick, like, what is the biggest challenge, do you think, to providing services in Kentucky, in Appalachian Kentucky? What would you say would be the biggest barrier to overcome?
I can start if that's right. I think it's having enough certified genetics health professionals to provide those services. We have a number of open positions in our area, and I think have a need for positions beyond that as well. And just recruiting people to come practice in the beautiful state of Kentucky and Lexington, and keeping them, retaining staff is really important and challenging.
Yeah, and I think I'd agree that the access to genetic counselors, and even some of the hospitals, like our cancer hospitals, that may not have genetic counselors on site, but even if they could partner with someone to help guide them, and like we've seen, I think a lot of benefit from our physician initiated testing, which we could maybe expand that to other cancer types, or something that other providers can do, while also ensuring that the patients are given access to a genetic counselor, even if it is like a phone call or a telehealth consult or something like that. So yeah, I think that access to professionals.
Do you utilize any sort of paraprofessional technical kind of support, like genetic assistance, or are you using any kind of those services?
So I know, Margaret, you guys have some genetic counseling assistants that you all have. We, like I said, we have some shared, and they do some genetic counseling assistant type roles, but they're not interacting directly with patients.
Yes, we have a genetic counseling assistant who is primarily involved with scheduling genetic counseling appointments, genetic counselor only appointments, monitoring authorizations for genetic testing, coordinating lab appointments for genetic tests, and triaging incoming patient referrals to genetics and metabolism.
Thank you. I see that there's a question from Dr. Fala, who is our clinical geneticist, medical geneticist here. Can you clarify, you mentioned that one barrier is low rate of reimbursement to genetic counselors, but on the other hand, the study showed that the revenue of 1.5 million in revenue by just one genetic counselor.
Yeah, so the reimbursement, so that's looking at if you're billing, $200 for a genetic counseling visit, many times the insurance might pay a percentage of that or none of that. In that downstream revenue study, they were looking at if a patient has like a BRCA1 or 2 mutation and needs to undergo additional screenings or surgeries, it was looking at revenue the hospital generated from those additional visits. So everybody wants to claim downstream revenue, and I think that's some issues that people have run into is like, well, the mammography group wants to claim that downstream revenue from biopsies and surgeries and all of that, but kind of looking at where it initially stemmed was from a diagnosis of a hereditary breast and ovarian cancer.
All right, so we have another question now. Do you think CMS, Medicare, Medicaid will offer reimbursement for genetic services in the future, or genetic counselor services in the future?
I hope so. There is currently a bill that is in the United States Senate that would recognize genetic counselors as healthcare providers through CMS. It's passed the House, so we'll see what the Senate says.
I keep saying this is the closest we've been, so we'll see. It's been something that they have looked at for years, but we're hoping that it will pass this time.
I believe it would really revolutionize our ability to provide genetic counseling services in the state of Kentucky. So I am hopeful that it will pass.
Yeah, it's challenging, right? Because it requires a lot of training, and yet we're kind of in the middle and not necessarily being compensated for that. So it's a challenge. I see another question. Can you explain if there's any disparity in genetic service utilization across Kentucky, and how can we bridge a disparity across the state?
I'll say from a cancer side of things. So in Kentucky, in Lexington, we are like the furthest east that there's a cancer genetics, group of providers. There is that one provider in Pikeville, so in far east Kentucky, and she provides cancer genetics, but she's only there twice a month. And so I think the western side seems to have more services across compared to the eastern half. So I think there is some disparity and ways to bridge it. I think telehealth will hopefully, I think that has helped a lot, because I know we've seen a lot more patients utilize that and have it not be such a barrier.
Yeah, I think there are geographic and socioeconomic barriers, and those are probably, that's my instinct, some of the biggest disparities and barriers for our patients. And I think meeting patients where they are with outreach clinics, or setting up sites where patients can go that are in their communities where they can access telehealth, like maybe a public health clinic. Kentucky has a kind of a centralized service for children. They used to be called the commission clinics. They're called something else now, I think. But perhaps partnering with those sites, and they're usually based out of public health clinics in various counties.
Definitely that geography. I mean, when you're comparing, the mountains in Appalachia, I mean, it looks like it's not very far apart on a map when you're looking at a flat map, but whenever you have these big mountains in your way, it takes longer to get places, and people are more spread out. So it's challenging. Is it Dr. Kaler or Caller? I believe.
Kaler, can you hear me all right?
Yes.
Good. Yeah, it's Kaler. I work with Margaret. What a nice bunch of talks. I wanted to say a couple of things. One of them is that the same areas that are hard to get to by road are also hard to get to by internet. So it hasn't really improved. It's improved how we can plan to see people, but the connections to Harlan and places like that have been sometimes very challenging. People may not have Wi-Fi in their home, and they sit in their car to get a better signal, but that's not so good either. that's a kind of accessibility issue for the mountains. That's more than just the roads. The other thing I wanted to mention is that there's a growing plain people, Amish, Mennonite, and such around Hopkinsville, Pembroke. And the physician there is Dr. I guess his name is Mock, but he's working with Holmes Morton, who created a clinic for special children in Strasburg, Pennsylvania. And I've been in touch with him about how can we help out that community with what we know how to do. The clinic in Pembroke is relying on lab services from Vanderbilt, but the newborn screening, which is how we first encountered what was going on there, is done in Kentucky. So the patients are Kentucky citizens, and we will help take care of them in Lexington and elsewhere. So that's another area of genetic patients that are going to be getting better service now that I've established connection with Holmes Morton. And he's very good. He's still based in Pennsylvania though. So this is another area where we will have plenty to do. And as a final thing out of that, when he was in Strasbourg, they set up a plain people genetic panel. Basically, all the mutations for all the disorders that are known in the community is one test, and it's not very expensive. And he says, for whenever you see somebody from that community, if you can check the parents, you'll know exactly what the children might have and what the possible combinations might be from just checking the parents. And then you can start working from there. You've already eliminated all the things they might not have, so you can focus on the things they might. Thanks.
Thank you. Yeah, when I trained at Riley Children, we worked with the Amish community some there, and it really is a very unique population with unique needs. So we appreciate your outreach to that community. I see a question from Alyssa Terry, who is from NIMAC, which is one of our regional genetics groups. Have you tried telehealth using local telehealth equipment sites? Can be local clinics, public libraries, etc., to help families with no devices or broadband?
That's how our MCCAN sites kind of operate, is that the patient goes to the clinic and is seen there, but those are the only patients that we see that way. The rest of them are seen through usually kind of Zoom, well, through our Epic platform now, but that's the only places we've done that. I don't know if Margaret's team has set anything up like that.
We have not, but I think that is certainly an option for patients who don't have access to technology or broadband service. The commission clinic that I had mentioned before does provide services in that way. The genetics is not involved with the commission clinics at this time, but I know our child neurology service performs telehealth in that manner. The patient will come to the public health clinic in their county or the nearest county, and they'll see the child neurology provider by telehealth from there.
All right, thank you. I think that's the end of our questions, and we're at the end of the hour. And I would like to thank our genetic counselors and clinicians at University of Kentucky, and our genetic counselor supervisors, Margaret and Justine, for a wonderful talk, both of you, and also for a nice discussion. And so again, we appreciate your feedback and learning more about setting a research agenda for research in the Appalachian area and how we can best service our population. So again, thank you very much to our speakers, and thank you all who have attended today. We appreciate it. Bye.
Thank you.
Thank you.